My name is Daniele Gui, and I'm the former director of the emergency surgery of Policlinico Gemelli in Rome. Today, we are here to discuss the topic of vaccination hesitancy among healthcare workers. We will look at different perspectives for tackling a complex issue, and for this, we teamed up with the COVINFORM project, No Fear and COVINFORM project. We would like to thank for their excellent collaboration. Next. Rachele? Okay. Please read our meeting rules and our behavior consequently. So, No Fear has been active in the last 3 years, and it brings together practitioners, decision and policy makers, suppliers, and researchers in the field of emergency medicine. The aim of this project is to enhance the cooperation and collaboration among different sectors, trying to overcome the fragmentation that exists in the field of emergency medicine. As No Fear project, that lasts for 2 years, we hosted more than 12 webinars on COVID in the last year. We discussed the various themes from logistics to nursing homes, from lung ultrasonography for diagnosis to disinfectants, training items, and ethical and psychological implications. You can find most of our webinars into our site or through YouTube. I'd like to pass, next. Okay. I'd like to pass the floor to Diotima Bertel, coordinator of the COVINFORM project. Diotima is a researcher and project coordinator at Senior GmbH. She has background in communication science, philosophy, comparative literature. In her research, she focuses on the intersection of science and technology, the social and societal impacts of technology, as well as the individual to societal, epistemological to ethical implications of technology. She has experience in national and European research projects, and she will shortly present the project. Please, Diotima.
Sure. I'm just, we'll mention a couple of words about the COVINFORM project, who co-organized this webinar with the No Fear project. We are a project analyzing and aiming to understand the responses on the COVID-19 pandemic. We started in November 2020 and now are able to present first insights of our research. And particularly, we have focused on communication strategies from different actors, in particular government and public health actors, and more later in our presentation.
Okay, thank you. Next, Rachele. Healthcare workers are particularly exposed to play a role in nosocomial transmission, which makes them an important target group for vaccination. Healthcare workers represent a high-risk group for SARS-CoV-2 infection. Their reluctance to be vaccinated against COVID-19 when present could diminish patient trust and trigger a negative cascading effect in the general public. Since vaccination is a complex behavior, understanding the way the healthcare workers take the decision to accept or not COVID-19 vaccination will give us the opportunity to develop the appropriate interventions to increase COVID-19 vaccination uptake. We will discuss the implications that come from COVID-19 vaccination hesitancy with the project COVINFORM and 5 experts from Austria, Italy, and England. On the right of the slide, you can see that the no-vaxxers are not something new. In the image at the bottom, on the contrary, you can see that this issue was discussed also by the American Medical Association, confirming the importance of this topic. This is the agenda, and now Barbara Juen and Alexander Kreb will discuss vaccination hesitancy in healthcare workers, psychological considerations. I will introduce Barbara Juen. Dr. Juen is the head of psychological support of the Austrian Red Cross, scientific advisor of the European Network for Psychological Support and the EFRC Reference Center for Psychological Support. Alexander Kreb is a psychologist working at the University of Innsbruck as part of the working group for the emergency psychology and for psychotraumatology. Is active in psychological services and is a Red Cross volunteer.
Thank you very much.
Please, Barbara.
Yes, I'm here. Thank you, Professor Goy, for this introduction. Rachele, do you share my slides? Can you hear me?
We can hear you, Barbara.
That's good. Then I'm just waiting for the slides, but I can already, okay, good, thanks a lot. I will talk about vaccination hesitancy from a psychosocial perspective. You can give me the next slide, Rachele, thank you. What has already been said is that we see that healthcare workers are very, very important in vaccination in different forms. One importance is that in Austria we see, but also in other countries, we see that people, they go to healthcare workers in their vicinity, to those they trust for information about vaccination and other things. What we see, for example, in psychiatric patients, but also in other population groups, is that if their medical doctor, their trusted family doctor says he has got vaccination, then they also get vaccination. So healthcare workers are the most important multipliers of informations and role models in pandemics for many things, but also for the vaccination. You can give me the next slide. So the difficulty is that doctors, nurses, ambulance personnel are also an especially critical and difficult audience. What we see is that they have to be informed proactively. What we saw in some hospitals is that they didn't inform nurses and doctors beforehand because they thought they are healthcare workers. They can inform themselves. They know where to find the information. But this didn't work. If you didn't inform them proactively, only 50% of them got vaccination. So one thing is that also this group has to be informed properly. The other thing is that they have to be listened to. A dialogue had to be established with them in order to find out where their concerns lay. And if you didn't listen to them beforehand, they didn't get vaccination, or only 50% did. their participation has to be one, first of all. We always knew that also from other pandemics. And they have to be coached and trained also how to communicate with the population and with their patients. You can give me the next slide. And an additional problem that we have at the moment is that healthcare workers are under a very big strain in this pandemic. We are seeing in our longitudinal data that over the time frame of this whole year, they are losing their job commitment, or many are losing their job commitment. They say, I'm staying now, but after the pandemic, I'm changing my job area. They feel they are maltreated and not taken seriously. Stigmatization and aggression towards healthcare workers is rising all over the world. They lose trust in themselves and in the system. And all this correlates to vaccination hesitancy, because we see in many studies that the stress that people have has a high correlation with vaccination hesitancy. So the more stressed people are, the less they get vaccination. You can give me this next slide. Thank you. In Austria, what we see at the moment is the general population is between 15 and 70% pro-vaccination. This agreement changes with the pandemic phase, with the target group and with vaccines. Target groups who are not well reached at the moment are women, younger people, migrants, caregivers, especially in the sector of elderly care. Also in the hospitals, we had problems in the beginning, but these problems, and in the ambulance sector, we had problems with the younger people, but these problems have been solved by better communication. Characteristics of the target groups who cannot be reached sufficiently is low socioeconomic status, low educational status, and exception are the women, because we have a big discussion on AstraZeneca, and here it's often the more educated women who say they don't want to be vaccinated with this vaccine. Can you give me the next slide? It's especially difficult to reach nurses and caregivers in the elderly sector. Their characteristic in Austria, at least, are often migration background women, younger age group, low socioeconomic status, low educational status, and a very special problem we have in the hospitals and in the elderly care sector with the cleaning personnel. They don't get vaccination enough. And part of this problem is a problem of information and myths. One of the main myths that are around is that vaccination leads to infertility. In hospitals at the beginning, there was a big hesitancy because they didn't proactively inform, and they didn't go into the dialogue. This has been solved in many hospitals very well with better communication and with an involvement of the head nurses. So if a person whom you trust gives you enough information and goes into a dialogue with you, then the vaccination hesitancy got down, and now we have in the hospitals between 70 and 80%, and also in the Austrian Red Cross we had the same experience in the ambulance personnel, but here it was mainly the young people who didn't get vaccinated or didn't want to get vaccinated. But with the same strategies, this could be ameliorated. We have growing problems in crisis communication in this pandemic. I'm talking about Austria, but I think it may be similar in other countries. There are more and more contradicting messages from the decision makers. There is a decrease in trust in the decision makers and the management. There are gaps in communication. Some people are not reached because we don't use their channels, we don't use their language, we don't use their role models. There are myths around. And also this 100% ideology. We have to reach 100% protection from COVID, and everybody wants 100% protection and no acceptance of insecurity and risk. And this is also a problem in communication. There's no realistic view on the change from a pandemic to an endemic situation in the autumn, and many people, even decision makers, ignore problems that might come in autumn because the population immunity will not have been reached. You can give me the next slide. So what we recommend, I am also in an advisory group for the health minister, and we recommend to enhance the trust in international, European and national healthcare institutions and to strengthen their data quality and accuracy. We recommend mainly that you have to stop the all or nothing communication, like the vaccination either works 100% or doesn't work at all, and the side effects the same. There have to be no side effects at all. This is a problem in the way decision makers especially communicate to the public. We could make use of our old prevention concepts. We always said you have to have a long-term vision, you have to anticipate problems, and you should not use a no-risk picture. We have also to enhance self-efficacy with positive messages, like before we said the virus dominates us, and now we start to dominate the virus. And we have to stop this 100% myth. If we reach 70% of the population, for example, we have reached a very important goal. And we have to use nudging, which is already used now, so that people see the positive effects of vaccination. Okay, next slide. There are 5, we also use this 5C model, the obstacles against vaccination. It's about confidence, trust, it's about complacency, it's about the risk perception of people, it's about constraints, how difficult it is to get the vaccination. You can give me the next slide. It's also about calculation. Some people have a lot of information, but they have too much information, and this makes them insecure. They need somebody who guides them through the information. And the collective responsibility problem, that we all know that there has to be a pro-social motivation and altruistic motives. But if people at the same time do not perceive self-efficacy, this doesn't work at all. So what can we do? In the next slide. We can try to work against the myths. We can try to give information and to use trusted role models. What we see is that if we use trusted experts that communicate directly with the personnel, vaccination hesitancy goes significantly down very fast. We have to develop realistic risk awareness without using fear as a motivator. We have to use visualization. We say you have to, at the same time, you have to give the good message, but also the bad message, the hope and the fear message, not only one or the other. You have to work against obstacles, and it's not good to make vaccination obligatory, but opting out strategies are okay, and nudging may work, and all other strategies. Next slide. You can help people to navigate through information jungle, but still you need these trusted experts. And again, we are with the health. We had a problem with a group of younger people in the ambulance system. And what we saw is if you take time and listen to them as a trusted expert in the system, you have to take your time, you listen to them, you talk to them about their concerns, you take them seriously, you don't use this 100% and no risk communication strategy, then you can win them. And you have to inform about protection of the public. You have to inform about what the vaccine can do and cannot do, and for whom we do it. For example, in the autumn, we will do it for the children because they are the only ones who cannot get vaccination. Next slide. I'm already, and my last slide is now, what we also see is that it's very important at the one hand, it's about information, but on the other hand, it's also about recognition and about taking them seriously, about giving them better working conditions. It's about protection for healthcare workers against stigmatization and aggression. Healthcare workers need to see that the systems, including their organization, cares for them and learns from the crisis. And leadership selection and training is very, very important. We saw this throughout the whole crisis, how important it is to coach the leaders through this pandemic. And their training and selection must involve social competence and knowledge on good crisis communication and psychosocial support. And we think that until before the pandemic, often leadership in the healthcare sector was trained mainly in a way in the direction of economics and not so much in the direction of psychology and social competences. Thank you very much. That's the end.
Thank you very much, Barbara, for your speech. And I already introduced Diotima, so I give her the floor. Please, Diotima.
Thank you. Could you also introduce Sue, who's doing a presentation with me? Okay, well, thanks very much. I will put this presentation together with my colleague Sue Anson from Trilateral Research, who is involved in both COVINFORM and the No Fear project. So our focus is on societal and communication considerations of vaccination hesitance, and we will mirror or connect to some of the things that we've just heard. Give me 1 second. There's someone waiting in the turn in the lobby. Okay. Yeah. So to give you a brief background, these results are based on a COVINFORM project that I've introduced in the beginning, which has started in November and is running for 36 months, conducting several case studies to understand the impact of the pandemic and the pandemic response on vulnerable groups. But we also include insights from other H120 projects, in particular Eunomia, Perceptions, No Fear, and Stamina. And now I'll hand over to Sue.
Thanks, Diotima. It's a pleasure to be here today. So I just want to start by providing some background information on vaccination hesitancy. So what do we mean by vaccine hesitancy? It's the belief that a vaccine may be unnecessary, ineffective, or unsafe. The WHO has listed vaccine hesitancy as one of the top 10 threats to global health in 2019. And it also varies across time, location, and vaccine type. The later presentations by Elena and Rita are going to present some statistics on differences across countries and different groups on the intention to get vaccinated. It's also important to acknowledge that vaccination hesitancy is multidimensional and multifaceted. So while me and Diotima can talk about some of the sociological considerations and the communication considerations, we're very aware that there are other considerations such as legal aspects that we aren't covering today. Vaccine hesitancy is also influenced by complacency, convenience, and confidence. Complacency relates to the perception of the disease risk. Convenience is associated with availability, affordability, and delivery of the vaccine in a comfortable context. And confidence is the very flip side of vaccine hesitancy and relates to the perception of vaccines being safe, effective, and that there's competence of the healthcare system. And as we mentioned, it's a very complex and context-specific issue. Next slide, please.
And let's try again. As Barbara's mentioned already, it's very important to have healthcare workers on the side of communication because they are the most trusted advice and influence on vaccination decision, especially if they're located within specific communities. So they must be supported to provide trusted and credible information on vaccines. And they're also able to bridge the gap between healthcare policymakers and patients. So what happens if this specific group is hesitant to get vaccinated, and what can be the reasons for it? We looked at surveys across the whole world, and we could see that trends in these surveys are mirrored. Trends in surveys on the general population are also mirrored within the healthcare workers as a subgroup of the general public. So general trends include the level of education and income, as well as ethnic minority populations and lower levels of education, as well as members of ethnic minorities are more often uncertain and hesitant to get vaccinated. And on the other side, we could see that individuals who are males, who are of older age and who are highly educated are more likely to accept the vaccine. Another influence is perceived risk or fear of being infected with COVID-19. So direct patient contact lowers vaccination hesitancy. And then as an overall trend, we can see that vaccination hesitancy is reducing as the pandemic progresses. And what you can see here is an example of communication campaigns, so two examples, one from Austria and one from the UK. And you see that in both of these campaigns, healthcare workers are used as trusted spokespersons. However, there's also criticism on these approaches, for example, due to a lack of representation or diversity in the spokespersons that are used.
Okay, and thinking about the different reasons for vaccination hesitancy, I mean, some of these overlap with those provided by Barbara, but a lot of them are concerned with the perceived risks versus the benefits of the COVID vaccines. Studies have found concerns about safety, efficacy, and the side effects, and they're the three main reasons for COVID-19 vaccination hesitancy. There's also studies that have shown that previous experience with healthcare providers that can put people off wanting to have the vaccine. There can be mistrust of doctors, health authorities, government sources, pharmaceutical companies, and scientific research. And as we'll show on the next slide, this experience can be different for different groups, and it's not that all groups have the same experience with healthcare providers. There's also religious beliefs that might prevent people from having the vaccine. For example, if there's a perception that the vaccine has ingredients that certain religions don't want to take, that may prevent them from having it. Also, there's cultural, group values and peer group perceptions of the vaccines as well that may prevent people. There's also costs associated with taking the vaccine, and it's not only thinking about the cost, but it's also a question of accessibility and what barriers that restrict people from being able to have the vaccine. It may be that it's in a location that people can't get to, and there's other considerations that they need to think about. And as Barbara mentioned again, there may be a lack of knowledge and awareness and information about the vaccine that prevents people from wanting to take it. And there's some questions on the side there about different concerns that we've identified. People are concerned about vaccine safety, about how quickly it was developed, and also about differences across different groups as well, and whether there may be different side effects for different groups. And these individual reasons are connected to cognitive, psychological, socio-demographic, and cultural factors. Next slide, please. And it's also important to think of healthcare workers as a vulnerable group in themselves that needs to be considered when thinking about vaccination hesitancy. We're all very aware of healthcare workers having a higher risk of exposure due to the nature of their occupation, but there's also the fact that the occupation intersects with other characteristics that can increase the impact of COVID-19 on this group. For example, 76% of healthcare workers are women in the EU. 23% of medical doctors and 14% of nurses in the EU are migrants. And 21% of people employed by the NHS in the UK identify as Black, Asian or minority ethnics. And these are all factors that may go into that decision around vaccination. And related to this, healthcare workers are not a homogenous group. They include doctors and nurses, and those that provide indirect care and services, such as aides, helpers, and medical waste handlers. But the important thing to note on this slide is that vulnerability is not an inherent condition, but it's caused by a variety of different structural drivers. And so vulnerability will be different in different contexts.
Among the intersecting factors that Sue mentioned is the minority or the migrant background. People of ethnic minorities were involved as healthcare workers. Worldwide, this is a significant amount, and in particular among frontline healthcare workers. And among minority ethnic groups, we can find specific barriers to vaccine uptake in general that also apply to COVID-19. And those are quite diverse. They range from language barriers to specific risk perceptions, from socio-demographic context to, as Sue already mentioned, inconvenience and access barriers. But also things like lack of representation in vaccine clinical trials, distrust of public services due to a history of structural racism or experiences of inequality. Also, and that's connected to the communication campaigns that I've mentioned before, lack of communication from trusted sources, from sources they can relate to, or lack of endorsement from community leaders. And also, there might be inequalities in the labor market that make these groups hesitant to follow measures and to get the vaccine. For example, the inability to work from home due to the kind of work they're doing as frontline healthcare workers, or the inability to get paid leave. And in general, a lower confidence in vaccine may be connected to some ethnic minority groups. And what is also connected to this, and in particular to the whole infodemic that has been accompanied the COVID-19 pandemic. An infodemic, it means an overload or an overwhelming amount of information that is mixed with misinformation. And this infodemic, or this amount of misinformation, in particular in the context of health-related disasters, can place people at increased risk. And misinformation has been identified already in studies as a driver of vaccination hesitancy within healthcare workers and within the general public. And in particular, this can become a problem if misinformation sounds scientific or mimics the way scientific information is communicated. If we read headlines such as head of Pfizer research says COVID-19 vaccines is female sterilizations, or if we read misinformation about microchips that may dissolve under the skin, even though these kinds of statements may sound ridiculous at first, if they mimic scientific information, they can become quite convincing. And some misinformation is more obviously recognizable than others, but also the exposure to it in the first place can become harmful because of what we call the truth effect. And the repetition of that information just has an effect on us psychologically. So she will end our presentation with some recommendations on what it is we can do in general about vaccination hesitancy and also misinformation.
Thanks, Diotima. So I think, echoing what Barbara said again, and I think the strong thing is that there's a lot of commonalities between the two presentations, is that there's a need to avoid coercive and punitive measures and stigmatization. Having a vaccine is a very personal choice, and it's really important that blame isn't attached or any stigmatization to those groups or people that make the decision not to have the vaccine. But it's also really important to understand the different factors that contribute to vaccine hesitancy. As we've presented already, there's a variety of different reasons, and it's important to understand what they are, and also to address the variety of concerns that different groups may have. It's also important to provide accurate information on and education on vaccine safety and efficacy. It's important to have this ongoing dialogue. It's really important to build trust and confidence, and to have conversations with different groups, and to understand what their concerns are, and then develop interventions that address those concerns. And also, instead of blame, it's important to share experiences of the consequences of taking different actions. It's also important to tailor health messages and advice to reflect local realities. Going back to one of the first slides, thinking about the local context and who are the trusted sources of information in that community. What are the different considerations that a local community will have, and responding to those and developing tailored materials. It's also important to make both communication and vaccine provision accessible. It's not only about having communication in a particular language, but it's also making sure that it can be understood by the target audience. And there's a number of different factors that will come into play with that. And as we mentioned before, about making vaccine provision accessible, it might be about a location, or other factors that may prevent people from taking vaccines, and considering those and developing responsive interventions. And again, using trusted spokespeople, and this may not be the same spokesperson for each group. Some groups may have a different community leader or person that is trusted, and it's important to recognise that and develop interventions that account for that. And finally, it's important to be transparent and provide evidence for the decisions that are taken. For example, some groups are prioritised with the vaccination rollout, and it's important to communicate why those decisions are taken so that they can be understood by different target groups. Next slide, please. And these recommendations are provided by the WHO SAGE working group. And again, it really echoes what we've already said, but it's about clearly identifying and understanding who our target audiences are. What are their particular needs around vaccine hesitancy, and addressing those needs? As we've said numerous times, it's really important to have meaningful engagement. So trying to avoid top-down information that we don't know has been understood and interpreted by target audience. It's important to have dialogue so that we can address those concerns and respond to them. It's also important to account for contextual influences. As we've already mentioned, there may be different factors preventing people from having the vaccine. It may be religious, or it may be related to gender, for example, concerns about infertility as a result of the vaccine. So it's really important to think about the context and ensure the communication responds to that. It's also important to have multi-component interventions. A TV campaign may only reach one target audience, so it's important to be responsive to those different needs and have different strategies to engage with different target audiences. And it's also important to evaluate different interventions. We understand that it's time consuming, but I think we can only really know the effectiveness of the intervention through the evaluation process and learning what has worked and what hasn't worked. Next slide, please. And this is our final slide, and it's taken from the Eunomia project. And the Eunomia project focuses on combating misinformation on social media. And the project is developing a number of information hygiene guidelines to help people identify misinformation and how to respond to that. And one of the recommendations we saw in the literature is about working with healthcare workers to identify and refute misinformation. One of the very important recommendations that is coming out of the project is about something potentially be misinformation, do not share it. But there's also in identifying and refuting misinformation. For example, I know I've seen campaigns myself where there's the rumour about COVID vaccination causing different side effects, and there's actually been responses where people have stated that area of misinformation and then provided the correct claim as well. But that's our last slide. Thank you. And we have some references here in case anyone wants to follow it up afterwards.
Thank you. Close the microphone. Thank you. Someone has the microphone. Thank you, Sue. Too many thanks to Sue. However, I didn't introduce Sue Hanson. Sue is a senior research manager at Trilateral Research, a research and technology development SME based in the UK and Ireland. Sue leads and contributes to projects and research related to disaster management, COVID, social media, and so on. Thank you for your presentation. Now the floor is to Rita Murri on the item, the healthcare workers' perspective. Rita Murri is a professor of infection disease in our hospital, Policlinico Gemelli in Rome and Catholic University. She's involved in COVID and she has experience in health correlated quality of life and patient-centered measure. Please, Rita, the floor is yours.
Thank you very much, Professor Gui. It's an honor for me. Thank you to also to the previous speakers, because many issues of presentation are now presented. Probably we can discuss a point of view of the same issues. Can I have slides, or can I share my presentation?
You should be able to show yourself, Rita.
Okay. Okay.
Not yet.
Please let me know. Again. Okay. And now
We had only a flash.
I sign of a try again. I want to share my slides direct from the host.
Just give me 1 second.
Mhm.
Good.
Thank you very much. This is so magical and so. Thank you very much. So, next slide, please. I tried to skip some issues that in the presentation, the definition of hesitancy, we know very well now. As previously cited, the vaccine hesitancy is one of the top 10 threats toward health. Next, please. As we require an 80–85% of to be vaccinated to have immunity. Hesitancy is around 30%. You can see here the systematic review on the rate of hesitancy, and probably this is the very common rate of hesitancy worldwide. Next, please. Characteristics linked to the rate of willingness are several, and probably we can age or ethnicity or education, please. And very curiously, kind of some occupation type are related to a lower willingness to be vaccinated. For example, here, the first responder and also involved in construction and maintenance are less prone to be vaccinated compared to other kind of occupation. Okay. This a paper we published a few months ago about the attitude toward vaccination. And again, there are some very interesting characteristics that are linked to hesitancy. For example, having information from Facebook group or some being young, and also the attitude towards the vaccination for flu is related to rate of hesitancy. So to resume, as previously cited, education level, ethnicity, poor people, cognitive impaired, or for some people, young people, less digitally literate, people with really school and unemployed are more to be hesitant towards vaccination. This is very important to be known because it's the base for eventually for intervention or for information campaign. Next, please. Sometimes we believe that healthcare worker attitude must be always positive towards vaccination. However, as previously cited, healthcare workers are not an homogeneous group. Most of healthcare workers are not experts in the field of vaccination, and sometimes we know that immunization is not an important part of the initial healthcare worker. Next, please. So, looking at the reasons for COVID hesitancy, maybe adverse effects are among the most important reasons for being hesitant. But in the distrust against, for example, healthcare workers or DA process and so on. Next, please. Yeah, again, report the field about vaccine content and the side effects are among the most cited ones, and also having little information about vaccine or having doubts about the efficacy of vaccine are among the most cited reasons of hesitant. Next. And it is the result of very interesting survey in the United States, again, about characteristics of all hesitant people, and very curiously, and all people, Democrats, Republicans are more available to be vaccinated, well as health workers and white people and so on. Again, here are very, very common sentences that we believe in our words. What will happen with every day message or say I'm allergic to everything. What happens if I'm intolerant? Happens if I have poses. What about if I was pregnant? And unfortunately, it makes more presence on media, social media, compared to right information. And as before, probably Barbara cited, we are in crisis in last year. Please. So the link about hesitancy and social media is a very important issue. Unfortunately, extensive anti-vaccine content is shared across social media, and the magnitude or repetition of negative content, anti-vaccine content, unfortunately has a larger impact on the perception of this religion, so that even magnitude and events leads to a big repercussion. Sometimes also have to understand the some of disinformation to the misinformation. Next, please. My personal representation of hesitancy along the time is not linear. As you can see here, hesitancy is high at the start of vaccination or even with vaccination program. We have regular decrease or increase in hesitancy. Next is as we go ahead with the vaccination program, the hesitancy in a very proportion decrease. However, as you see here, we have some regularly peak dropping. Next is just correlated to news communication on social media. For example, in my opinion, an irregular in hesitant after communication and way and the type of communication, adverse events linked to the AstraZeneca vaccine, as well as the Johnson & Johnson adverse events and communication social. In the same way, we could have also an acceleration of the decrease in hesitancy, for example, when vaccination becomes mandatory, for example, healthcare workers in Italy, or a vaccine passport to travel worldwide. Next, please. Here, there are some papers on REP that try to link rate of hesitancy according to time of survey or measurement that is highly variable. Should take into account for our research this kind of ability in the time. Next, please. Here again, the United States survey, as you see here, hesitancy is really different from January 2021 to December 2020. And we probably the hesitancy really significantly decrease as soon as vaccination go ahead. Please. And maybe we can skip the slide next, please. So the trend is probably different among here, for example, some part of the population that has the same level of hesitancy even after the vaccination program started. Here again, a summary, the reason for skeptical people are several and very different, from fear of adverse events to fear of genetic manipulation, fear again about fertility, information, discuss in healthcare system or providers, problem related to conspiracy, belief, issue again the symptoms, especially for very high people, misperceptions about COVID severity gain deep and cultural so that even the hesitancy to vaccination is now a critical issue. Probably the reason of skeptic people, the sum of all scientific reasons, and combines scientific evidence, trust in healthcare, trust in policymakers, social benefit, approach of benefit for all, the hope of the end of the pandemic, and really think that among most potential supporters to us is very important for combined people. Next. This is only a graphical representation. I want to, this is a very interesting report in New England Journal of Medicine from Lisa Rosenbaum. Just look at the difference of risk perception for people. So the magnitude of benefit, for example, of vaccination may have less or more emotional presence than the possibility. So the perception risk is very, very important to be considered in this kind of problem. Next, please. So going ahead to strategy to overcome hesitancy. So what we can do, we can participate to increase the willingness and the participation in vaccination program. Probably all these points are previously cited from Barbara and Sue and transparent information on is very important, and even to I don't know, probably people are very happy if explain ways on the obscure zone of our knowledge and seeing confusing communication. And about if we have some certainty, probably we should spread the right information. We should take into account the grade of the health consequences, probably don't render more correctable with us. Here I present also a very interesting just published a few weeks ago about the effects of written vaccination information. Next slide. Besides written vaccination could support the decrease in rate in significant of hesitancy in other populations. Other strategies to overcome hesitancy leverage on social media, the endorsements by figures. Interesting. I read the sentence from people in the United States. If Fauci approves it, we will go for it. So even acting on community-based organization is very important. Again, a structural change, social media communication is warranted, and going from most frequent to gain from messages. So from negative message to positive and hope-related messages. Next, please. Again, address barriers. I think this is a very common conclusion of our speeches from the speeches of this webinar. So probably it's very important to address patient barriers and not escape them and approach to countering misperception. So vaccine hesitancy and cannot be addressed by changing or giving more or better information. Probably we can cope with misperception and with reluctances. Important also the appeal to altruism and try to apply as a behavioral changes technique and an interview, just going from stigma to empathy. Next, please. So probably my last question is, we as healthcare workers to engage and listen. Probably this could be key of hesitancy reduction in our population. Next, please. I ask you to, yes, next, please. I keep some about motivational interview. If you want, we can discuss. Please. Next, please. Some tools, some instruments to be used for education and vaccination motivation tools. Next, please. And my final slide, why getting the public to understand science may be insufficient, maybe it's also time for science to understand the public. Thank you very much for attention.
Thank you, Rita, for your presentation. And now, least but not least, Professor Elena Ambrosetti, who will speak on the demographic perspective. Elena Ambrosetti is Associate Professor of Demography at the Faculty of Economics and affiliated to the Department of Methods and Models for Economics, Territory and Finance, Università La Sapienza of Rome. Currently, she is the coordinator of Sapienza team of two H2020 projects, Perceptions and COVINFORM. Her main research interests are international migration in Italy, with special attention to migrants integration, migrants policies, and so on. Please, Dr. Ambrosetti.
Good afternoon. Thank you very much, Professor Gui, for introducing me. And thank you very much also for the invitation to both No Fear COVINFORM projects. I'm very happy to be here and to present my perspective on this important and relevant issue, that is the hesitancy of healthcare workers about COVID-19 vaccination. I will share my screen. Okay, and can you see the slides?
Yes.
Yes, yes, yes.
Perfect. Okay. Okay. So first of all, a lot of issues have already been addressed, and I completely agree that, of course, it's very important for the healthcare workers to communicate, and to the science in general, to communicate with the people because today, for instance, I was talking to my students and two of them expressed a different kind of worries about the vaccination. One is against the vaccination because she's not sure about the pharmaceutical companies and so on, and she do not trust the government. And another one told me, I'm going to get vaccinated, but I will not get my daughter, that's 11-year-old, when the vaccine will be available also for children. I will not get her vaccinated. So you can see that it's, I was struggling to convince them about about getting vaccinated. So my presentation will deal with three main topics. Firstly, I will introduce the different policies that have been developed and adopted over time in the COVINFORM countries. Specifically, I will focus on the COVINFORM countries, actually in some of them, because data are not available for all of the COVINFORM countries. And then I will present briefly also the real statistics on the vaccine, COVID-19 vaccine uptake among healthcare workers in some of the COVINFORM countries, where for those countries that already provided the data on the vaccination uptake among the healthcare workers. And then I will we will have a look to the attitudes on vaccination that actually have been already addressed in the other presentation. So about the policies, we have a different perspective in several countries about the priority categories. So those who were given priority in the vaccine distribution, and most of them were the most vulnerable populations. But here the approach, I mean, the definition of vulnerability was quite dissimilar among countries. And among the vulnerabilities, also the one to be directly exposed to the virus, especially so for the healthcare workers, was considered in several countries, but not in all of them. And also among the healthcare workers, different degrees of vulnerability were assessed and recognized by different countries. Let me explain a little bit more about that. So I have here we have the details about the vaccination campaign that in most countries, as you are well aware, are organized in different phases, in different stages. And because, of course, especially of the vaccine availability that was really poor at the very beginning of the campaign, most of our countries in Europe, but also in Israel, that is also one of the COVINFORM countries, but it's an exceptional case somehow. I will comment at the end of the presentation about Israel. So we have some countries such as Austria, Germany, and the UK that differentiated also the priority among healthcare workers. So they recognized that some of them had high risk of infection because of they were working in the front line with the COVID patients, for instance. And then there were also some of them that had not this frontline exposure, so they were considered not as high vulnerable and not at high risk, and therefore they were not vaccinated starting from the very beginning, from the phase 1. For instance, in Austria, they had phase 1 and phase 2, and in phase 1 only high risk healthcare workers at high risk of infection were vaccinated in the second phase, also the rest of the healthcare workers. In Germany, that they were divided in 3 different stages, and in the UK there were 2 stages, but in other countries, for instance Belgium, but also Italy and Spain, from the beginning of the campaign, all the healthcare workers were allowed or were eligible to get vaccinated. So of course the priority that were given by the policymaker are of course relevant, especially in a situation where we had a scarcity of vaccine, a lack of vaccine, and so the government were somehow forced to make a decision about who were the most vulnerable population. But of course, the definition that was adopted by the government was really restrictive somehow. We had the healthcare workers, and in most of the cases also the population over a certain threshold of age, but we know that vulnerability is not only by age, but is also by occupation, for instance, by gender, by ethnicity, by geographical location, by socioeconomic condition. So it's quite a complex concept, and to operationalize it was not straightforward for government, and of course many categories were not happy with the priority scale that was adopted. As far as the data collection is concerned, we are struggling actually to get the information about the vaccination uptake among healthcare workers. Not only the total number of vaccines that have been already uptaken by them, but also about their age and their characteristics, because as you already have mentioned, that the other colleagues have already mentioned during their presentation, healthcare workers are not an homogeneous category. It's quite understandable. So we have so far a few information, and most of them are related to the uptake of first and second dose. For instance, here we have the statistics for in some countries of the COVINFORM project, not every country, about the number of healthcare workers, the percentage of healthcare workers that have already been vaccinated with the first and those or fully vaccinated. And we can see that even in countries where the vaccination started from all of them for the very beginning, so at the end of December, we know that there is this 27th of December that was the vaccination starting then all over the European Union. They have not reached, with the exception of Romania, 100% of vaccination among those that were that are the population of the full population of the healthcare workers, that which definition is also not really straightforward, and we can also discuss more about that point. These are some statistics that I have found for the Italian specific case. So we have the number of, we have again only raw numbers of the people that have been vaccinated according to their age. But for instance, at a certain point, we had also the stratification by gender, but then it was quite complicated to get this stratification also by gender. And at the same time, I also found strange, as you can see, we have people that are over 80, that it is also very strange to me, but then I have, I understood that people are included in the category they belong to for their profession, but also by age, so it's, I mean, it's quite complicated also the way they collected statistics. And here we have the percentages, always in the Italian case, by people that have been vaccinated. Here we have the first and the second dose, of the fully vaccinated, and then those who received only the first dose. And also on the left side you have the fully vaccinated figures, and on the right side the percentage of those who have already received the first dose. And this is by region, and so you can notice there are also important differences by region. In some region, all the healthcare workers received at least one dose. In other regions, they did not. I don't know here. I don't have an explanation. Maybe the colleagues that are healthcare workers can help me in this. But of course, there are different rate of vaccination in the different Italian region. That's an explanation. But here I see at the very bottom of the category of the percentage of those who received the first dose, 3 regions that are not among the worst performing for the whole population. So there could be a hesitancy among the healthcare workers that is most concentrated in some Italian region, that is also to look for. So last point is the attitudes on vaccination, how they are changing over time. And here we have the results of a survey that is administered each month on people behavior and response about COVID-19 in general. And this is a survey that is realized by the Imperial College of London. And among other things, people were also asked about their willingness of being vaccinated against COVID-19. And there is, of course, an evolution. And here, again, we have only 5 countries that are also members of the COVINFORM project. And there is an increase over time of people willing to get vaccinated. The figures in this graphs are between November and 2020 and February 2021, and especially there is an important increase in the vaccination, in the willingness to get vaccinated in the UK. That is quite relevant. And we will see also in the others, and the last slide, that the attitudes on vaccination. And here we have another. It's the same survey, but at the same time they changed also the way they ask questions because of the evolution also the vaccination campaign. So here we have in different colors, different population. So in red, we have those who are not vaccinated, are not willing to get vaccinated. In orange, we have those not vaccinated and uncertain in willing to get vaccinated. And then we have in dark blue those that already received a vaccine, and in light blue those that didn't receive a vaccine but willing to receive a vaccine. So what we can see is that, and we have different countries. We are on the left, on the top left of the slide, we have Spain, and then following in the clockwise, we have Italy and Sweden, UK, and Germany. What we can see here, there is a hardcore of people that are not willing to get vaccinated. That is very evident in the last months of the survey. That is from a couple of countries, is April, so it's very recent, and this is for Italy, for the UK, and for Germany. And the skeptical are also quite stable over the last 2 or 3 months of the survey. And generally speaking, I found that it's quite amazing this difference. I was watching also I was looking also at the data that I think Rita was showing for the US, and the UK also is similar to the US with the number of people that are not willing to get vaccinated. It's quite lower compared to the other European countries, where it's quite stable, and it's around 20% of people that are resistant to get vaccinated. So I don't know what is the reason behind that. We should look also at the other determinants or the characteristic of the population, not only the willingness to get vaccinated, of course, to have a better understanding of those figures. So this was my last slide. So to conclude, what we also have as an experience that I would like to report for the COVINFORM project was the interview that we had, that is also available in our website, with the deployment of the vaccination campaign in Israel. And there are a lot of insights also in how they succeeded, or at least they tried to make people less hesitant with a community, for instance, based approach. And you know that Israel is a very diverse country with several ethnicity, several also religion. So that was really interesting to understand how the Israel David Macdon succeeded in getting in touch with the community leader, religious leader, for instance, and also with the family network, to get people less hesitant and to get people vaccinated. So thank you very much for your attention. And
Thank you, Dr. Ambrosetti, for your presentation. And I would ask the floor if there is some question. We received 2 questions. I propose the first one. I would like to ask if the possibility of choosing the type of vaccine could help in overcoming hesitancy. Is there any one of the speakers that want to answer?
I can say. Sorry, there was a bit an echo. I think it's a very good question, and I don't think I have a definite answer to that. But what I do think, this is one of many factors choosing the vaccine, in particular the bad press that some of the vaccines have gotten. So while this potentially could help to address vaccination hesitancy, we have to look at all the different factors that play a role in this whole context. So I think we need to be aware of the role of the media in the whole process, and how different vaccines have been communicated, how efficacy has been communicated, and I don't think it will be the only answer if it's just that. So we need to do more than just that.
Okay, thank you. Any other one want to intervene? Second question, please. Rita?
Okay, no, just share some observation. I completely in favor to let people to choose. However, the possibility of choosing the vaccine introduce another quantity of confusion, because if you look at the social media or material that are now available on YouTube and social media and so on, you can see that many products are now just to let people understand the differences among different vaccines. So I'm afraid that having the possibility to choose introduce also another point of confusion. This is.
Okay. And the second question, what do we do with the healthcare workers who do not vaccinate? Will there be a job restriction for them?
Me again? This is a very big issue. This is a very big issue that is not only a clinical or a public health issue, it is also a societal issue, because it is the debate between freedom right to protect. So it's difficult to question. You know, Italy now the vaccination for healthcare workers. Just to let you, to share our experience here in clinical journey, we observed that is a significant is of vaccination without more or complete reaction. So I think that is just functionality that needs to be pushed or to be straight. If I support information, consideration of the point of view of health whether rest to immunity that's for any difficult point.
Thank you very much, Rita. Any other questions? No. So I thank all of you for presentation and for staying in this webinar. Sorry, there is an echo. I cannot understand where it comes from. All right. I take the opportunity to remind you our contacts, and feel free to reach out and stay connected. Sorry. There is a question from Tom. Tom, is there a question from you? Ma mi sembra... Please, could you hear me?
Yes.
Tom? Tom Flynn posed the question, has the WHO issued a statement regards healthcare worker being vaccinated on a compulsory basis with notable exceptions? Is there anyone who wants answer?
There are some to basis for vaccination that are some allergy to complex vaccine or some health condition that are trained to vaccination. This is included rules.
Okay, thank you. Other questions or answers? No. So, thank you for your attention, and feel free to reach out and stay connected. Do you hear me?
Yes, thanks very much.
Oh, thank you, and see you next time.
Bye-bye. Thank you.
Bye-bye.
Bye.
Thank
Bye.
you.
Bye.
Thank you. Goodbye.
Bye.
Thank
you. Bye. Thank you.